you very much. So I'm going to talk about secondary stroke prevention. That is preventing stroke in somebody with atrial fibrillation who's already had a TIA or stroke. That's sort of where I come in to the atrial fibrillation picture, because nobody meets me unless they've had an event or at least are at very high risk for an event. And I always consider it a shame when any patient comes to see me with atrial fibrillation, because I think having a stroke with AFib is always a letdown of the medical system for the patient. We're so good at preventing these strokes if only patients would take their medication. But in fact, in the United States, at least, half of people with atrial fibrillation who should be on any blood thinner, Warfarin, Pradaxa, you name it, are not taking a blood thinner at all, or are only taking aspirin, which is really not very useful in atrial fibrillation. So we have a lot of work to do, at least in the United States, to get people to even take a blood thinner, let alone choose the right one. Here are my disclosures, and let's imagine the following patient, who I think will illustrate a lot of the dilemmas that we face. Imagine this man, about 70 years old, admitted to the emergency room with acute onset of left hemiparesis. He is taking warfarin, but like 45% of the patients taking warfarin, his INR is not therapeutic. Making this statistic even worse is the fact that when people are not therapeutic on warfarin, they are too low 2/3 of the time and too high only 1/3 of the time. This is a perfect storm, because when your INR gets below 1.9, the risk of stroke goes up rather quickly. So it's actually better to be a little bit over anticoagulated. It's pretty safe to have an INR of 3.1, 3.2, or 3.3. Bleeding really takes off over 4, and yet we as doctors tend to undertreat rather than overtreat our patients. This particular patient had his onset of symptoms 1.5 hours ago and didn't have any bleeding on his CAT scan, so we can imagine that he was thrombolyzed, and now that we've determined he doesn't need a carotid endarterectomy and that the atrial fibrillation is the likely cause of his stroke, we have to go about thinking of how to best prevent another stroke from occurring. Some more details about this patient. He's 70. He's got paroxysmal AFib. You all know that that really doesn't figure into the discussion. Paroxysmal AFib is about as high risk for stroke as chronic AFib. He has the risk factors of high blood pressure and diabetes. He is said to have a labile INR. Most patients have a labile INR. The time in therapeutic range overall in the US is, as I mentioned, 55%. The best anyone can do in a warfarin clinic is closer to about 64 or 65%. So most patients spend a lot of their time out of range. His kidney function is good. He's now ready to take an anticoagulant. He's been off of it for a few days, which is common after a stroke. And he has a Rankin score of 2, meaning he is independent, also meaning, I guess, this is not really him in the wheelchair. So what is our biggest priority when we're selecting an anticoagulant? And I think it's fair to say that we really only have one main priority, and that's preventing both ischemic and hemorrhagic stroke. That's not only our priority as physicians. If you ask your patients, especially elderly patients, what are you most afraid of? They will tell you overwhelmingly they are more afraid of a disabling stroke that lands them in a nursing home or leaves them bedbound, dependent upon their family for care. They are more afraid of that than they are afraid of certainly a GI bleed, afraid of dying, afraid of cancer, afraid of all the other neurological horrors I could think of. A stroke by far is the number one thing on their mind. And I think if you deal with patients who have cardioembolic strokes and you see the devastation that is caused by these strokes, you start to realize that this fear of elderly people of having a stroke is appropriate, that in many cases it is better to die than have one of these giant hemispheric blowouts that atrial fibrillation tends to cause. It's also true that patients are willing, if you discuss it with them, to take some risk of bleeding to prevent a stroke. Doctors tend to want to do no harm first and foremost, which is admirable, but patients would rather take the risk of having, for example, a GI bleed or GU bleed and prevent a stroke than the other way around. So I think what has to happen to be more effective as a profession is we physicians have to start thinking more like our patients and worry more about stroke and worry a little bit less about bleeding. So what do we do when somebody has atrial fibrillation and high risk for a stroke? And of course, having a stroke is the number one risk factor for going on to have another one in atrial fibrillation. Well, we recommend anticoagulation, and the American guidelines at least give class 1 recommendations to warfarin, apixaban, and dabigatran. Rivaroxaban gets a class 2A recommendation because the data is not, in my view, as sterling as it is with the other agents. But anticoagulation with something is by far the best option in most patients, unless they have a prohibitively high bleeding risk. Now, what about putting this patient back on warfarin? You could argue he is a logistic warfarin failure because his INR was too low, but perhaps not a biological warfarin failure because his INR was subtherapeutic at the time of his stroke. This is not generally my approach. I use the novel agents first line. This would be better than putting them on any of the agents that are listed here, a single antiplatelet agent, dual antiplatelet agent, or as is often the case, nothing. So warfarin is better than nothing, but I think the NOACs or the novel anticoagulants are a better choice than warfarin. And the reason is, number one, the twice-a-day novel anticoagulants are superior for preventing total stroke, ischemic and hemorrhagic, compared to warfarin. All of the novel agents are dramatically safer for the worst complication of taking a blood thinner, which is bleeding in the brain. We'd like one with a reversal agent, which we now have one and only one that has a specific reversal agent, which I'll talk a little bit about at the end. And then, of course, we want one that's easy to take, and none of them have important drug interactions or food interactions, and none require monitoring, making a big advance compared to warfarin for convenience and ease of use. So if we look at the novel anticoagulants as a class, what you can see is that both for preventing the combined endpoint of stroke and systemic embolism and for hemorrhagic stroke, there is a benefit of novel agents compared to warfarin. And this runs the gamut of warfarin done not very well, which is how I would characterize the Rocket AF trial, where the time in therapeutic range was only about 50%, compared to warfarin done about as well as can be done in even the best anticoagulation clinics, as was done in the RELY study, where the time in therapeutic range was about 64%. This is even true for hemorrhagic stroke when patients spent the most amount of time in therapeutic range, which I consider to be quite miraculous. In fact, I think if you're not a neurologist, it may be easy to not recognize the significance of the reduction in hemorrhagic stroke that is seen with novel anticoagulants. I was in a car with a friend of mine who's a cardiac electrophysiologist who sees a lot more patients with atrial fibrillation than I do. And he said something to me that at first I couldn't believe. He said, "We really don't see warfarin brain hemorrhages, do we?" And I couldn't believe he said that because this is a guy that does nothing but treat and ablate atrial fibrillation, and yet he's telling me we never really see warfarin brain hemorrhages. And the insight that finally came out of that conversation is that the reason he doesn't see warfarin brain hemorrhages is that if somebody bleeds into their brain while they're taking an anticoagulant, they meet me in the neuro ICU on the way to the undertaker or the nursing home. 80% of patients who bleed into their brain on a blood thinner end up severely, permanently disabled or dead. Some people would call that dead or worse. And they don't need a cardiologist anymore. They end up either dead or in a nursing home. So that's why I think it's easy to not realize the importance of preventing hemorrhagic stroke, because when someone has an intracerebral hemorrhage on warfarin, they are largely off the radar, lost to the medical system. And so unless you happen to be in the business of taking care of stroke patients, you may not actually see them. Now, how do we choose among the NOACs? I think there are three factors that we need to consider when we are choosing NOACs, especially for an extremely high-risk patient like the one we're talking about with high blood pressure, diabetes, advanced age, and a recent TIA or stroke. Number one is prevention of total stroke, ischemic and hemorrhagic, as well as systemic embolism. And I say systemic embolism because that was an endpoint in all of these landmark trials, but in fact, systemic embolism occurs about 5% of the time of embolic events compared to brain embolism. So we're really talking about preventing embolic stroke. Dabigatran and apixaban were the only novel anticoagulants that were superior to warfarin for preventing ischemic and hemorrhagic stroke together. We also want to primarily prevent ischemic stroke, since by about 5-to-1, patients are at risk for ischemic stroke over intracerebral hemorrhage. The hemorrhages are a nightmare when they occur, but ischemic stroke is the biggest risk these patients face. And there's only one novel anticoagulant that beat warfarin for preventing ischemic stroke specifically, and that's dabigatran 150 BID. And then, of course, we want a lower risk of intracerebral hemorrhage and intracranial hemorrhage of all types, and all of the novel agents have this advantage over warfarin. So of all the choices I showed you, the only one that has all three of these attributes, a reduction in total stroke. Thank you. I was pressing the wrong button. Thank you. So of all of these agents, the only one that has all three of the attributes we want, reduction in total stroke, reduction in ischemic stroke, and reduction in intracerebral hemorrhage compared to warfarin, is dabigatran 150 BID, about a 25% relative risk reduction for ischemic stroke and a 75% relative risk reduction for hemorrhagic stroke. Now, what if this is a, let's say, a lazy patient or a patient that you think can't be bothered taking a medication twice a day? First thing I would tell him is, give me a break. You were just in the hospital with a stroke. It's the worst thing that can happen to you. Another stroke will land you in the grave or the nursing home. Don't tell me you can't take a medication twice a day, especially since the vast majority of patients with stroke and atrial fibrillation are taking medications twice a day already. But there's also a pharmacokinetic reason why we shouldn't worry too much about BID and why, in fact, it may even be better, and that's that patients forget medications all the time. I take medications. I sometimes forget a dose. In fact, I left one of them in Chicago, didn't bring them with me to Israel. I hope it's available here. But you can see that if you miss one dose of a once-a-day medication, your drug levels fall to the same level they would fall to if you missed 3 doses of a twice-a-day medication. And that's just simple pharmacokinetics. And so the consequences of a missed once-a-day dose are much greater than the consequences of a single missed twice-a-day dose. So I think this once-a-day dosing is a bit of a non-issue for patients, especially the high-risk patients. The only patients in whom I think it really is a major issue is somebody who is disabled and needs their medications, for example, pushed through a feeding tube. Somebody who's had a devastating stroke, is totally dependent on a caregiver. There, I think making anything you can do to make the caregiver's life easier makes once-a-day dosing, I think, a meaningful advantage. But in the average patient who's come through their stroke and is now living independently, I simply don't think it's a reason to choose a medication, that it's only once a day. If you look at secondary stroke prevention data from the RELY trial, you can see that there is good reduction in recurrent stroke with both the dabigatran 110 BID dose, which we don't have in the United States, and the 150 BID dose that's shown in red. The 150 BID dose, of course, being a little bit more effective for preventing stroke in general than the 110 BID dose. Now, what about in the real world? You probably are aware that Pradaxa or dabigatran was the first novel anticoagulant to be approved in the United States. And in that sense, it was the windshield that hit every bug first. And when the drug first came out, people were shocked that there were some episodes of bleeding. I personally didn't find it shocking. It's a blood thinner. If you give enough people a blood thinner, any blood thinner, people will bleed. But I think people thought this was going to be as safe as a lifesaver, and it turned out not to be. And there was a public outcry about the drug, leading Medicare and the FDA to analyze the real-world experience of patients prescribed dabigatran in general practice. And the largest of these real-world studies was done by Medicare independently of Boehringer Ingelheim. And what they did was look at about 130,000 patients on Medicare, which is our public health financing system, who were put either on Warfarin as starting therapy or Pradaxa as starting therapy. And these two populations were by design propensity matched, meaning they had roughly equal risks of stroke, risks of GI bleeding, risks of intracranial hemorrhage. And then they looked to see what happened to them. And the results were an astoundingly precise mirror of what was seen in the RELY trial. So what's shown on this slide are the results from RELY comparing Warfarin and dabigatran, and on the bottom, going down, the results from this Medicare comparative analysis of Warfarin and dabigatran. And it looks like this has just been reflected around the horizontal axis. It's a precise mirror of what was seen in the RELY trial. So in the general real-world population, just like in RELY, there were fewer ischemic strokes with dabigatran than with Warfarin, dramatically fewer intracranial bleeds, about the same number of total major bleeds, more major GI bleeds, and that is I would say the one downside of Pradaxa versus Warfarin is that there is an increased risk of major GI bleeding. And the fact that that was also seen in the Medicare population, I think argues for the statistical robustness of this analysis because it showed both the good and the bad that came out of the RELY trial. MI, you remember that there was a minor signal of an increased risk of MI that was not seen in the Medicare analysis, and there was about the same magnitude of reduction in mortality in the Medicare database as was seen in the RELY trial. Now, let's pause for a minute and talk about this GI bleeding risk, because I think we can't ignore it, and we need to know how to discuss it with patients. I told you earlier that patients would much rather have a GI bleed than an ischemic stroke, and I think when I discuss this decision with patients, and I recommend that they take Pradaxa, what I tell them is if you choose Pradaxa over Warfarin, and I don't tell them about the absence of monitoring because I actually don't want to bias them. That makes the decision too easy. If I tell them if you take Pradaxa, you can go home today and you're therapeutic in 30 minutes, I don't want them to decide based on convenience. I want them to decide based on something that's a little bit more important. So I tell them if you take Pradaxa instead of Warfarin, you have a lower risk of an ischemic stroke, which is obviously the point of the whole exercise, a dramatically lower risk of bleeding in the brain, about the same risk of all bleeding, but a higher risk of major GI bleeding. And patients, I think, understand that a GI bleed is something that most patients walk away from, not necessarily a walk in the park, not something you want to happen, but only about 10 or 12% of patients with AFib who have a GI bleed will die or be left disabled versus 80% of patients who bleed into their brain on an anticoagulant who die or are left disabled. And patients understand that stroke is much worse than a GI bleed, and they're generally willing to make this trade-off. So returning to this patient who's got good kidney function, just had a stroke, this is somebody I would put on Pradaxa 150 BID. Now, what if the patient had been taking Rivaroxaban? What if they had taken it and had a stroke despite taking it? Is there any guidance for what to do here? The answer is, while it isn't based on comparative studies, the ESC guidelines suggest using dabigatran because of its superiority to warfarin at preventing ischemic stroke, rather than the other NOACs in people who have had a stroke despite taking Rivaroxaban or apixaban. and that's also my practice. I use Pradaxa in the patients who are the highest risk for having an ischemic stroke, and somebody who's just had a stroke is certainly in that category. Now, finally, I want to give you the last piece of the puzzle, and one that I'm very excited about, and that I was involved a little bit in the research that led to it, and that is the reversal agent. And you see a little bit of a teaser in front of you on the table about this reversal agent, which is FDA approved in the United States. It's called cracksbind. Let me tell you just a little bit about it. You'll hear about it in more detail a little bit later. Cracksbind is a monoclonal antibody originally from mice, but made into a human-type FAB fragment that binds dabigatran 350 times more powerfully than dabigatran binds thrombin. So when you give this to patients intravenously, it sucks all the dabigatran off of the thrombin and actually sucks it out of the peripheral tissues as well, and binds it essentially irreversibly. The half-life of the complex is on the order of 72 hours in a test tube. The study that showed that this drug actually works or does what it's paid to do in patients who need it is called the REVERSE-AD trial. This is a trial which will have a total enrollment of 500 patients. We're now at about 350 patients worldwide, and we reported on the first 90 patients in the New England Journal of Medicine about 3 months ago. This trial enrolled 2 patient populations, which I think reflect the 2 populations in which a reversal agent will be used. Group A was patients taking Pradaxa who had life-threatening bleeding. So that's bleeding in the head, retroperitoneal bleeding, bleeding making them unstable, bleeding where the risks of taking away the anticoagulant were felt to be worth it because the bleeding was so severe. But unique to this trial, of all the reversal agent trials, is that we had a second population, one where I think we're going to see this agent used, which is patients taking Pradaxa who aren't bleeding but need emergent or urgent surgery. For example, patients with broken hips, patients who need cardiac cath, patients with appendicitis, taking Pradaxa where the physicians felt they couldn't wait 12 or 24 hours, they had to proceed immediately. Everybody in the study, it was single arm, got the 5-gram dose of cracksbind. For technical reasons I won't go into, it was given as 2.5 gram half doses, but the dose that we tested is 5 grams, and in fact that's the dose that the FDA approved. And the primary endpoint was reversal of the dabigatran coagulopathy, measured by the Eckerin clotting time or the dilute thrombin time, which are the 2 most specific assays for dabigatran activity. The endpoint was not survival or stopping bleeding because these patients are bleeding for a host of reasons: car accidents, trauma, amputations, all sorts of events. And taking the Pradaxa out of the equation doesn't necessarily stop them from bleeding. But what we want to do is at least normalize the coagulation parameters. And here is just the one data slide that I'm going to show you. If you look at the Eckerin clotting time here, in the first data point with this wide range is the abnormal Eckerin clotting time that we saw in patients who were taking Pradaxa, as expected. And even after the first 2.5 gram half dose, not more than 90% of the patient's Eckerin clotting times normalized. This dotted line is the upper limit of normal. Now, we don't have the Eckerin clotting time readily available, so we were also interested to see if we could see parallel results with a PTT, which is easily available. And we saw exactly the same thing with the PTT. You can see the PTTs were almost all abnormal when the patients rolled into the emergency room. We gave them cracksbind. Almost all of the patients' PTTs became squarely in the normal range. So there's really no doubt in my mind that this reversal agent does what you want it to do, which is take the Pradaxa out of the equation and allow you to focus on treating the bleeding and treating the patient. So to summarize, what is our main consideration when we're dealing with a patient who is high risk for stroke, and AFib, the answer is preventing stroke, both ischemic and hemorrhagic. All of the NOACs, in my view, have advantages over warfarin. Dabigatran 150 BID in particular is the only novel anticoagulant that prevents more ischemic strokes than warfarin, and that's warfarin done as well as anyone can possibly do it. And I really don't think that convenience, and in particular the once-a-day dosing, has any meaningful role in this discussion. And with that,